Today's guest is Dr. Michael Ruscio, who is a clinical researcher and best-selling author whose practical ideas on healing chronic illness have made him an influential voice in the ancestral and functional medicine communities. His practical approach to research and clinical practice, especially on the gut and microbiota, have earned him invitations to lecture at many influential international conferences and top health-related podcasts. Thank you for joining us, Dr. Ruscio, with your GI case studies and the gut-thyroid connection.
Hi, thanks for having me.
Thanks for joining us.
And I'm excited to, I'm excited to dive into this topic because, gosh, there's so much to discuss regarding the gut and then also regarding how it connects to the thyroid. So I guess I can just jump in if we're ready to go.
Let's go.
Okay. So I just want to start us off with a little bit of a, comment on the state of functional medicine, because I think if we better understand some of what's happening in functional medicine, we can better understand how to best serve our patients. And so I think many of us have had the feeling that sometimes functional medicine care seems expensive and maybe seems a bit excessive. And I know this is something that for years I've been hearing the little voice inside my head say, gosh, is there a way I can do this more efficiently with less testing, with less treatment, with less dietary restrictions? And I think some of that feeling is a outgrowth of the fact that there's some erroneous assumptions that more testing equals better results or that more treatment equals better results. And I would actually argue that neither one of these are true, and too much testing or treatment actually may be counterproductive. And in addition to this, it's a truth that we just have to be aware of, that information is a form of marketing. It doesn't mean that information marketing is a bad thing, but we just have to understand that information isn't always non-biased, and information can be used as marketing. And unfortunately, to some extent, this has led mechanistic speculation that favors something that a marketer wants to market to outweigh clinical research, because oftentimes the clinical research isn't quite as flashy, isn't quite as, I guess you could say, dogmatic. There's some nuances, and so it may not be as prone to selling things. And unfortunately, good old empiric medicine has kind of been forgotten. And if we look at the evidence-based pyramid, we see a good reminder of the way healthcare practitioners should be evaluating information, and especially if it's information marketing, and that information may be coming from a lab or a supplement company or a blogger or some type of health authority. If we try to filter looking primarily at summaries of clinical trials, we have meta-analyses or systematic reviews with or without meta-analyses. And what this will give us, again, is a summary of clinical trials. And why this is so valuable is because this is the most prone to match with what your experience in the clinic will be with patients or with clients. And so that's very important, because let's say we're trying to determine, for example, the effectiveness of fiber in those with IBS. Well, if we have, let's say, 20 clinical trials that have been done, what a wonderful thing to have a group of researchers go and analyze all 20 of those studies and summarize them and give an aggregate based upon what all the data shows. This is what a systematic review and or meta-analysis will show us. So it's important to be looking at that level of data, clinical trial data also, and try to take away as much as we can from that type of evidence when it's available, and not lean too heavily on observational studies, cell studies, or animal studies, which unfortunately sometimes are what's often used to market things, because you can find a cell study, an animal study, or an observational study to support almost anything. So I just want to lead with that, just to make sure that we're keeping this in the forefront of our mind, so as to help prevent us as the practitioners from getting misled. Because if we get misled, then certainly our clients and our patients don't have a chance, because they're coming to us for information and or for guidance. Okay, so in my opinion, what's really needed is a return to practical and cost-effective care, which is progressive, yes, but also conservative. So let's look at a case study now. And as we go through the case study, if people want to get more information on the case study, I've put the link to the page on our website where they can get some of these details. But let's go into a case study here about histamine overload that initially presented as what looked like a SIBO relapse. So a 46-year-old female presented with GERD, SIBO, tachycardia, an esophageal stricture, which is essentially and you can kind of think of it like a little bit of irritation or scarring in the esophagus, which can partially impede the esophageal lumen. And sometimes people with esophageal strictures feel like they get things stuck in their throat because of that. Her chief complaints were indigestion and heartburn, bloating and nausea, alternating loose stools and diarrhea, brain fog, feeling emotional and like she couldn't handle stress, and also cycle abnormalities. So definitely some of these things sound like SIBO. So here's kind of my write-up on this gal. Mary presents as a generally healthy 46-year-old female who has a good diet and lifestyle. She's experienced a slow progression of her chief complaints. Her reflux and heartburn dates back to about 18 years of age. Her symptoms are manageable with a low FODMAP and fast-tracked diet combination and supplements, namely glutamine and enzymes. However, she's still symptomatic. Her bowel regularity, consistency became worse after antibiotics, most notably after antibiotics for SIBO, and subsequently even more worse after antimicrobials for SIBO also. She reacts negatively to HCl and notices that the better she eats, the worse she feels. And this is actually a key tip-off to something that we'll come to in a moment. So my initial impression is that Mary may have dysbiosis secondary to the antibiotics, maybe C. diff, it may be candida, and a negative reaction to HCl, her heartburn, her bloating, and nausea may also suggest gastritis or even an ulcer. And that's important to keep in mind because I think sometimes in the natural health community, we're always thinking give acid, give acid, give acid, give acid. And there are certainly times and places for supplemental acid, but there's also a number of people that will not benefit and even be harmed by supplemental acid, so we have to make sure we remain objective. The esophageal stricture may be caused by the reflux and the heartburn, and the emotional instability and inability to handle stress may indicate female hormone imbalances or fatty acid imbalances. So at our second visit, we recommended some testing. We did a glucose SIBO breath test, a stool test through BioHealth, another stool test through diagnostics, and a blood panel. And we asked her to continue with her previous diet, the low FODMAP fast track combo. I also asked her to perform a modified fast using bone broth or the Master's Cleanse solution, whichever one appealed more to her, and also experiment with a short course, this would be a 2 to 4 day trial of a elemental or semi-elemental diet solution. We put on some curcumin, some vitamin D with K, magnesium, and an omega-369 blend. And I should note that curcumin may protect esophageal cells from dysplastic changes. The vitamin D has shown to be helpful in IBS, and emotional instability may be due to fatty acid insufficiency. So that's kind of the justification there. And we put her on some female hormone support, namely black cohosh, Don Quai, and J-Street, and also a upper GI natural prokinetic and a probiotic, actually three probiotics, a lactobacillus bifidobacterium blend 1, Saccharomyces boulardii 2, and the soil-based probiotic 3. And finally, we put her on an acid-lowering compound that contained melatonin, a few various vitamins, and some amino acids. So essentially, we had her keep the same diet, try some fasting, did some nutritional support with vitamin D, magnesium, and omega oils, some female hormone support herbs, and some gut support with prokinetics, probiotics, and an acid-lowering compound. So we see her back 2 months later, and essentially all of her lab work came back negative. SIBO negative, both stool test negative, blood panel generally normal. And what about her subjective assessment? Regarding the fasting, Mary did not respond well to fasting, and she even experienced a regression of her heartburn and her stomach upset. And that's actually key to note, because when people have a degree of gastritis, they actually may do worse with fasting. So that's important to keep in mind. So if you have someone fast or they notice that they feel burning, gnawing, irritation when they don't eat, that's often indicative of gastritis or even an ulcer. Now, from some of the supplements in her plan, she noticed improved heartburn, moderately improved PMS and brain fog. Her bloating and nausea got better, and her alternating loose stools and diarrhea got better. So definitely some of what we did was working. Additionally, she noticed that the natural acid-lowering compound caused fatigue and was not well tolerated, probably because of the melatonin. And she also attempted to reintroduce gluten-free flours and starches, and this caused a regression. I did not recommend this. She just kind of wanted to try it, and so that did not go well. So overall, she remarked she felt about 75% better, and she also said she wasn't sure if the probiotics were helping or not. So we're seeing some things improve, some things not improve. We definitely established that fasting did not work for her, and that some of our interventions were helping with her gut and with her female hormones, but not everything was remedied yet. So my impression here, the negative response to fasting reinforces reflux, ulcerations, or gastritis. This should make Mary a good candidate for acid-lowering interventions. However, unfortunately, she was unable to tolerate this the acid-lowering formula that we tried, and her response to natural prokinetics was therefore not surprising. So what can happen in reflux in someone with normal acid is that they don't have good upper GI, essentially, motility, and this is where an upper GI prokinetic can be helpful. Also, if she reacted negatively to HCl and negatively to fasting, both of these indicate either high HCl or a little bit of gastritis, which can be remedied by a short course of dampening stomach acid, but again, she did not tolerate that. Her PMS and brain fog improving suggests that the fatty acids and hormone supports were needed. And I made a note here that there's really no need to test, in my opinion, the female hormones when using herbs that have adaptogenic effect on balancing female hormones as we did, right? Because if the herbs will be corrective, then the initial lab work doesn't really matter because you're going to give the herbs no matter what, and the herbs are going to be correcting the imbalances no matter what. So this is a great example of where we can save a patient some money and some hassle of doing like a month-long, cycling female hormone profile. And finally, overall, I think Mary's moving in the right direction. Of course, she's not totally, resolved all of her symptoms yet, but she's moving in the right direction. So the recommendations here were to discontinue the natural acid-lowering compound, avoid starches and gluten-free flours as best you can, discontinue any modified fasting or use of an elemental/semi-elemental diet, and continue the previous low FODMAP fast-track diet, continue with the curcumin, vitamin D, magnesium, and omega oils, additionally with the female hormone support, with the natural prokinetics, with the probiotics, and we'll follow up again in 2 months. So essentially here, we're just reading her response and advising her to continue doing more of what appears to be working and stop doing what appears to not be working. And sometimes it's really as simple as that. There's not a need for an incredible amount of testing to steer the ship. You just have to kind of read the science. And so here's her labs. Essentially SIBO, completely unmarked, nothing on her ovum parasite, and a very mild elevation of cholesterol, nothing that I was really worried about. Okay, so we see her again 2 months later, and Mary had generally maintained her previous improvements with the following exception, and this is really key. She had a runny nose, even though she was not sick. Abdominal pain was flaring, nausea was flaring, anxiety was flaring, and palpitations were flaring. And she also reported that she feels better, she feels better the worse she eats. And she also noted that when she eats lots of fermented foods and or kombucha, she feels worse. And I've noticed that when patients say that they feel worse when they eat better, that oftentimes can indicate a histamine intolerance. It's not a 100% correlation, but oftentimes what I notice people end up doing is they're eating more fermented foods or more lower carb foods that are oftentimes high in histamine, which again, can include fermented foods like kombuchas or sauerkrauts or kimchi, but also may include things like spinach, avocado, and it's overloading their system and they're not feeling well. So my impression here, the fact that Mary was experiencing a flare of runny nose, even though not sick, abdominal pain, nausea, anxiety, palpitations, as we just went through, are highly suggestive of histamine overload. She also reported that too much fermented food intake seems to flare her, further suggesting histamine overload. So we had her follow a low histamine diet and discontinue all probiotics, which are a source of histamine, while maintaining the previous treatments that we went through before. So the recommendation here, follow a low histamine diet, discontinue all probiotics while maintaining your previous program, follow up in 4 to 8 weeks. So in 4 to 8 weeks, what we see here, and sorry, this is kind of small, but essentially all of her symptoms are now gone. The stomach pain is gone, reflux is gone, runny nose is gone, stools are normal, bloating is normal, brain fog is normal. And Mary commented that she felt the low histamine diet was very, very helpful. She also noticed that the Lactobacillus bifidobacterium blend probiotic and the soil-based probiotic caused negative reactions, but the S. boulardii was actually okay. And that's important to mention because in my experience, response to probiotics are very, very individual. So I advised her to come off all probiotics just to be on the safe side, but she noticed benefit from the S. boulardii. So we said, fine, keep going with that. And my impression, reducing Mary's histamine load was helpful and was the last piece needed to be addressed to reach full symptomatic resolution. The fact that she had been off of a natural acid-lowering agent suggests this was not needed for her heartburn, reflux, or stomach pain. Interestingly, histamine is involved in gastric acid secretion, so by improving or reducing her histamine load, we likely address the root cause of her hyperacidity that may have been present. It's important to encourage Mary to adhere to whatever follow-up her conventional gastroenterologist is recommending to make sure someone is keeping an eye on any potential histological changes or damage in the esophagus, because sometimes the damage can be silent. There can be silent reflux. But hopefully our work together will ensure that her esophageal tissue improves, and but we just don't want to leave this to chance. So we want to make sure she maintains her regular conventional follow-ups. And the interesting thing, just as a side note about histamine, the more I've been looking into this, you oftentimes will see patients who have seasonal allergies also be more prone to having reflux and heartburn when their seasonal allergies are flaring because of the impact of histamine on gastric acid secretion. Additionally, keep in mind that histamine antagonists are one class of acid-lowering medication. So certainly histamine is involved in gastric acid. So the recommendations here were essentially to continue the program that we had previously been doing and work to expand your diet boundaries in the future since we had achieved symptomatic resolution, and then follow up in about 2 months. And she followed up in about 2 months or 2 months later. She had maintained all of her improvements and even reported she was feeling slightly better, and she had been able to slightly expand her dietary boundaries. So Mary has done great. No more improvement is needed. We can maintain this program for a few months and then start curtailing her off of the items in her program and try to find a minimal supplement program that would be suitable in the long term. And I just recommended follow-up in 2 to 3 months for kind of a routine follow-up. So, and here's some comments I'm not going to read through now, but essentially just highlighting some things I thought were noteworthy there. So that was a case of histamine. And again, I'm just putting this slide up here in case people want to reference back to these things. This is from our clinical training newsletter, which is a monthly publication, which can be found at drruscio.com/review. And this is the index of different months. And I'm just putting this up there so in case you wanted to dig into some of the details, you could refer back to it. Now, there's another important point I'd like to cover, which is lower carb diets and thyroid autoimmunity more specifically, because there seems to be some confusion regarding the role of carbs in thyroid health. And oftentimes you hear that a low-carb diet may damage your thyroid. And, you know, that's not really true. Now, a long-term ketogenic diet may cause negative metabolic consequences because you're essentially going into a pseudo-starvation response or a prolonged fasting type response, which can cause multiple negative reactions in the body. But that's not really damaging one's thyroid. It's just causing negative perturbations in one's metabolism because of a prolonged fasting or starvation type response that can occur in some when they're ketogenic, which is very low carb for an extended period of time. But that doesn't damage the thyroid, and that's not the same as a lower carb or a carbohydrate restricted diet. So this study entitled Effects of a Low Carb Diet in Overweight Subjects with Autoimmune Thyroiditis, Possible Synergy with CHREBP. I'll explain that in a minute. So essentially, the study wanted to assess the impact of a diet devoid of carbs, bread, pasta, fruit, and rice most namely, and free from goitrogenic foods, including dairy, on thyroid function, thyroid autoimmunity, and body comp. So said simply, they wanted to see what would happen on a low-carb diet. Again, a low-carb diet and a ketogenic diet are two different things. So the intervention, 3 weeks on each diet. There was a treatment, there was a control. The treatment had essentially a diet that was equivalent to about 200 grams of carbs a day, and they were instructed to eat leafy greens and other types of vegetables and only lean parts of red and white meat and avoid goitrogenic foods. So the following items were excluded: eggs, legumes, dairy products, bread, pastas, fruits, and rices. And the researchers described it as a protein-rich diet that was implemented for 3 weeks. So something here that many of us probably advise, right? It's a general carbohydrate restriction, and it also cuts out many allergenic foods like legumes, dairy, and breads, pastas, right? The other group, the control group, was a simple low-calorie diet that's more in alignment with kind of your low-fat, higher-carb dietary advice. And this is a diet that was recommended by the NIH, or I'm sorry, the National Research Institute on Food and Nutrition. So what happened? This is really the key question here. So in the treatment group, there was a 40 to 44% reduction in thyroid autoimmunity as assessed by thyroglobulin and TPO antibodies. And that is fairly significant. That's almost a halving. So that's very significant. Now, what about the control group? Let me go back, sorry. There was a significant increase in thyroglobulin antibodies and also a non-significant increase in TPO antibodies. So clearly, we are showing that a carbohydrate-restricted diet can be helpful for thyroid autoimmunity. Now, additionally, there was no negative changes in thyroid hormones reported between group. The lower carb diet group experienced slightly better improvements in body composition, and this is actually really interesting. 83% of the patients with high levels of antibodies were breath test positive for lactase, meaning they expressed lactose malabsorption or lactose intolerance. And so that's actually really important. And this suggests that there may be not only a component of restricting the obvious things like gluten, which may be problematic, but also by restricting some of the carbs in general, most namely dairy, and because these people may not be able to process lactose, there may be a degree of carbohydrate malabsorption, and somehow that carbohydrate malabsorption may, when addressed, may actually improve thyroid autoimmunity. So the authors conclude that this diet could be implemented for the treatment of patients with autoimmune thyroid and possibly reduce inflammation in the general, in general and in the thyroid gland. So I'm not going to read through all of this, but just one thing here, a simple low-carb diet around 200 grams that removes dairy, bread, and focuses on meat and vegetables can both dampen thyroid autoimmunity and improve body composition. So it's important to keep that in mind, and also to keep in mind that this was not ketogenic, right? 200 grams a day is a restriction of carbs, but it's certainly not a very low or ketogenic type diet. And it wasn't highly meticulous. these patients weren't put on the autoimmune paleo diet that's very restrictive. They were just restricting some common allergens as best they could, and they saw some nice outcomes. So hopefully teaching us that we can get good outcomes in thyroid autoimmunity with some simple changes, and we don't necessarily have to go to the most restrictive diet plan that's available. And this begs another interesting question, coming back to thyroid antibodies, and this is the reference that's supported here. I'm not going to put this up on the screen because it's a little bit involved to get into. I'll just give you the summary. Essentially, this study found that TPO antibodies, thyroid peroxidase antibodies, which are the most common blood test used to assess thyroid autoimmunity, when the level is below 500, it was associated with minimal risk of progression of thyroid disease and progression to hypothyroidism. Why that's important, or let me give some context. Usually 30 to 35 is the cutoff, meaning you should not be above 30 to 35. Now, where this gets confusing is what happens when a patient comes in and their level is 285. Or maybe to put this in terms of what you may see in practice, someone initially comes in, they were just diagnosed with Hashimoto's, they're trying to make some changes, they're not on a healthy diet, and they work with you for a little while, and their antibodies go from initially being, let's say 1100. Now, they improve their diet, they improve their lifestyle, maybe they take some vitamin D and fish oil, what have you. They lose weight, they feel better, they sleep better, they have better energy, their skin looks better, right? They globally improve, and their antibodies now drop down to 325. That's still considered positive. And the mistake that I think is made by some providers is telling these patients that they still have a problem, that they're still at risk, that they still need to do more, diet harder, be more restrictive, take more probiotic, do heavy metal detox, whatever it is, when in actuality it's starting to look like when people are in the low hundreds. I like to see people between 100 and 300. This study suggested below 500, which I think is also reasonable. But when people have thyroid antibodies for TPO in the low hundreds, that's a clinical win. And it's important to keep that in mind because it will still be labeled positive on one's lab work, but it's really a very good position to be in. And this study helped to substantiate that. Now, you also have to be careful because there's a couple of studies out there that have defined Hashimoto's as having antibodies above 100, so TPO antibodies above 100, and then the researchers conclude that people who have thyroid antibodies above 100 are at or have a higher level of essentially anxiety and depression. And what can throw people off is thinking that that means you shouldn't have thyroid antibodies above 100. However, if you read the study, the average level of antibodies in this group was 1,122. So they defined Hashimoto's as being above 100. And yes, the people with Hashimoto's did have poor psychological outcomes, but most of the people in the study weren't, didn't have TPO antibodies around 100, 200, 300. They had antibodies in the 1100s. So that's important to keep that in mind. So what this really draws back to is if you can get someone down to the low hundreds, then you've achieved a good endpoint, and you don't necessarily have to keep giving them more therapies, more vitamins, or more restrictive diets. Now, this study here is very interesting regarding the gut-thyroid connection, and here's the PubMed link and the title, but essentially, just to paraphrase, what this study found was that two of the most predictive factors for if someone would have SIBO was if they were diagnosed hypothyroid, and they were even at more risk if they were diagnosed hypothyroid but now being treated with thyroid hormone. So it shows, and I'm sorry, I should mention that in this study they were also looking at things like immunosuppressive drug use, acid-lowering medication use, previous intestinal surgery, And they found out of all those, two of the most significant predictors of if someone would have SIBO were being frankly hypothyroid, and even more at risk were those who were being treated for hypothyroid, which tells us that it's probably not due to thyroid hormone levels, because if that were the case, people who are hypothyroid would have a higher level of SIBO than those who are on thyroid hormone, because people who are on thyroid hormone are now in the normal range for their thyroid levels. But what it likely means is there's something about thyroid disease independent of thyroid hormone levels that predisposes one to SIBO, or small intestinal bacterial overgrowth. And this is really important for today's provider to be aware of, because it really shows that many of the patients or clients that you will work with who have thyroid conditions have a decent likelihood of also having SIBO. And by improving that SIBO, we have a good likelihood of improving their symptoms globally and potentially also their thyroid function. And there's a few other things that kind of tie in with the thyroid connection. This second study here showed that SIBO is more common in those with H. pylori. And I'm sure people here who are ordering lab work notice that it's not unusual to see someone with SIBO also have H. pylori. And then finally here, there's one meta-analysis that shows an association between H. pylori and thyroid autoimmunity. And the last study here is for an Italian study that showed treatment of H. pylori can actually reduce thyroid autoimmunity. So SIBO, thyroid autoimmunity, and H. pylori all kind of seem to function in this web, this interwoven circuitry. And it illustrates that we really want to make sure to optimize someone's gut health who has a thyroid condition, because in my experience, oftentimes it's the symptoms that someone is complaining of are not being driven by a problem with the thyroid once they've been on thyroid medication and have their levels in the normal range. It's actually being driven by a problem in the gut. Okay. Now, regarding H. pylori, if any of us have treated H. pylori, you may notice that you can't always clear it. I don't find, generally speaking, H. pylori is something that's difficult to clear. However, sometimes it has to be retreated. And what this study did was they took two groups of patients, group A, group B, who had been treated for H. pylori in the past, but been unable to clear the H. pylori, and treated them one more time. One group was pre-treated with N-acetylcysteine, which is actually an anti-H. pylori biofilm agent, and the other group was not treated with the N-acetylcysteine. Both were then given antibiotics, but it was the group that was given the N-acetylcysteine before treatment with the antibiotics that had a 65% eradication rate, whereas the group that did not receive the N-acetylcysteine only had a 20% eradication rate. And if you're not familiar with biofilms, essentially a biofilm is a protective coating that bacteria and or fungus can secrete over themselves to make them less prone to eradication by antibiotics. And N-acetylcysteine is an over-the-counter natural agent that has some antioxidant and even glutathione enhancing characteristics. So it has some secondary health benefits, but it also helps to degrade biofilm, namely H. pylori biofilm. So this is something that can be helpful in this gut-thyroid web. If you're seeing H. pylori, and H. pylori that's difficult to eradicate, the simple co-administration with N-acetylcysteine may greatly enhance the ability to clear H. pylori. And this is data from my clinic. We're currently submitting this for publication. I feel like I've been saying this forever now because I've been a bit delayed in getting this paper fully published, but we've crunched all the data and we're in the process of submitting this data for publication in a peer-reviewed medical journal. But essentially what we did here was we treated half of our patients with SIBO with standard herbal antimicrobials. That was the control, and the treatment group received the herbal antimicrobials plus antibiofilm agents. And you see here the control versus the experimental group in terms of reduction in gas levels. And you see the experimental group had a significantly higher reduction in gas levels for both hydrogen gas and combination gas. We did not show a significant reduction in methane gas, but we did for hydrogen and combination gas. And so this again shows that in some cases of resistant or hard to treat imbalances, infections, or overgrowths, biofilm or antibiofilm agents can be helpful. And so just to transition to probiotics in SIBO and in IBS, I think many of us are probably privy to the fact that probiotics can help with IBS. I just want to put up here that there have been 2 meta-analyses showing quite impressive benefit for IBS using various probiotics, most namely Lactobacillus bifidobacterium blends are best, potentially a blend that has bifidobacterium infantis in it, and a dose of anywhere from 100 billion to 900 billion can be used, and usually it's best to start with 100 billion and work your way up. Now, what's more contentious is the use of probiotics in SIBO, and I've put in here essentially some details. We don't need to go through all of the particulars, but essentially there have been a number of clinical trials that have shown that probiotics can be a standalone and effective treatment for SIBO and reduce gas levels and or also reduce symptoms. Now, this is not to say that someone with SIBO may not negatively react to probiotics. So there is a potential for a negative reaction to probiotics in SIBO, but bacteria, probiotics that is, secrete antibacterial peptides. So probiotics, ironically, are antibacterial, which is probably why, or in part, that they have their effect. Now, when looking at probiotics, I like to organize probiotics into 4 general classes, and what this can do is really prevent trying every different formulation out there in the market. And I know not everyone would agree with that, but as I've looked at just a wealth of probiotic studies, you see that many different formulas produce similar effects. And when you look at enough studies, you start to see the probiotics kind of consolidate into 4 general categories, and I'd recommend trying these different categories with the people that you work with to find which ones may benefit them. Category 1 would be a Lactobacillus bifidobacterium blend. So predominantly what you'll see on the label are Lactobacillus and bifidobacterium species. Category 2 would be Saccharomyces boulardii. And you'll see just on the label, of course, Saccharomyces boulardii. Potentially some Saccharomyces cerevisiae in there also, but predominantly Saccharomyces boulardii. And then thirdly, your soil-based probiotics or spore-forming, and you'll see predominantly Bacillus species. And then fourth and finally is E. coli Nissl or E. coli Nissl 1917, which unfortunately you can't buy it in the States any longer, but it has been studied in a number of clinical trials and shown to be beneficial, especially for those with ulcerative colitis. So I would try each one of these and see which ones may be beneficial or not beneficial for a particular person. And to my earlier point, why do probiotics help with IBS? They may be antibacterial, this is the anti-SIBO angle. They may repair and reduce leaky gut. They may be immunomodulatory, and it's important to keep in mind that most probiotics do not colonize you, and even dead probiotics have been shown to be helpful. Okay, and what I do, I essentially start patients with a moderate to low dose of a Lactobacillus bifidobacterium blend plus S. boulardii plus a soil-based probiotic. For sensitive people, I have them introduce these one at a time every few days and discontinue if any of them cause a reaction. The most common reaction is bloating, and it's important to note that not everyone tolerates probiotics, but I find that most do. Caution with the formula that you use, that the prebiotic contained in the formula is under about 100 milligrams. If you go much over that, you increase the likelihood that you may get a negative effect of bloating from the prebiotic contained in there. And I'm curious on E. coli, but you can't get it in the U.S., so it's much harder to orchestrate. Okay, and also it's important to note in time, I like to work to reduce the dose. Many people end up on a small dose, But it's important to always try to be working toward the minimal dose possible, because sometimes something that once helped can later actually cause detriment. So it's important not to think because something helped on day one and now you're 8 months later that they still need the same dose that they did before. Okay, and then this is just brief, but fiber and prebiotics are often a question in terms of how to use, what to use, and I want to just paint a broad perspective, because there's definitely some details here, but I think starting with a broad perspective is very important. And that essentially is the more symptomatic someone is. So if they have IBS, the more severe their IBS. If they have IBD, the more severe their IBD, their Crohn's, their ulcerative colitis. Or just the more digestive symptoms they have, meaning the number of symptoms, the severity of symptoms, the frequency of symptoms, the more likely they are to negatively respond to prebiotics and fiber. And that's really important to keep in mind, especially in lieu of all this interesting research on the microbiota that kind of pulls one into a direction of feed bacteria, feed bacteria, feed bacteria, because it definitely has been substantiated by the clinical literature that those with the most digestive impairments are at the highest risk of harm from feeding bacteria in the gut. And this is why we may see, coming to the slide here, why low FODMAP and low fermentability, like SCD diets, have pretty impressive results with IBS and with IBD. And again, fiber and prebiotics can help, but I think the utility has been overstated. Fiber may help or harm. Again, the less symptomatic, the less the risk. The fiber type matters. Lowest risk with soluble fiber, and this is most relevant for supplements, and IBS subtypes matter. Most benefit for those with constipation. So for someone who's constipated, you have the most likelihood of benefit, and that benefit is most likely to come from a fiber that is predominantly soluble fiber. And prebiotics, very similar, may help, may harm. The less symptomatic, the less risk. The ideal dose, likely between 3.5 to 5 grams a day. This has shown benefit with minimal risk of side effect, and many of the studies that have high rates of adverse events are when using higher doses of prebiotics. Now, prebiotics probably have the most impressive documentation to lower blood sugar. However, in some of these trials, they're using 20 grams a day. And you see the conclusion that for the patients that can tolerate it, it worked great to lower blood sugar, but many could not, because that is a very high dose. Okay. And since we're coming up on time, I'm just going to summarize this very quickly. Essentially, this is a study looking at the effect of the low FODMAP diet. And the study purpose was to evaluate the effect of the low FODMAP diet compared to, a high prebiotic intake in those with IBS. And essentially what they found was when patients went on a low FODMAP diet, the majority of them improved, about 80% improved. When those patients then either continued on the low FODMAP diet or started taking a prebiotic, 80% maintained the improvement who stayed on the low FODMAP diet. And only 30% of those who went on a prebiotic maintained their improvement. So we essentially saw the low FODMAP diet helps. When people adhered or continue to adhere to that diet, they continue to have improved symptoms. When people go on prebiotics, the majority of them relapse. And what's also interesting is, let me see if I put this in here. The patients experienced quite a worsening of nausea, vomiting, headaches, belching, and gas. And not in this study, but in another study, it was shown that inflammatory markers also increased in those who went on prebiotics. However, when mapping their microbiotas, ironically, the patients that had increased inflammation and flared symptomatically look to have what we think is a quote-unquote healthier microbiota, whereas those who maintained a low FODMAP diet and had less inflammation and less symptoms had what looked like a less healthy microbiota, which illustrates that we're pretty early on in our understanding of the microbiota. And my thinking there is that in people with IBS and IBD, the microbiota is not the cause of the problem to a large extent. It's actually the immune system of the host that is probably a bit overzealous and prone to react. And so the skewing of the microbiota is an adaptation of the immune system. And when you try to force a higher amount of bacteria into that immune system, you start to have negative reactions. So it's my thinking, again, that namely in IBS and IBD, a lot of the microbiota community skewing that we see is a positive adaptation by the host because they have probably an immune system that did not form with ideal balance. And so the way to compensate for that now is to partially trim back the microbiota, because if there was a more robust microbiota, that would irritate or trip the immune system and cause an inflammatory reaction. So I hope I'm not getting too deep there. Okay. And again, just briefly, I want to mention that we do have the clinical newsletter. I always feel like there's never enough time to get into all the details. So if people do want to get more details about this model of functional medicine they advocate, we put out a monthly clinical newsletter. There's one case study, 3 to 5 research studies, 1 question of the month, and 1 practice tip. And all that information is available at drruscio.com/review. That's the homepage there where you can plug in and learn more about that. And with that, I will bring it to a close, and I guess we can open it up for questions.
Okay, great. Thank you, Dr. Ruscio. That was very interesting. Going back to the probiotics, where do you start? Do you start with like a triad of probiotics, or would you start with a 1 or 2 and build up? Could you give us kind of where you start, how you dose, and how you kind of taper down in that duration?
That's a great question. And what I've been doing for the past few months, and I've really found a lot of utility in doing this, is I stagger the start of my interventions. So typically on the first day that we start intervening with the patient, we'll have them make some dietary changes and also start on a few different supplements. And what I'll do is usually ask someone to be on the diet for 2 weeks before starting on any supplements, and then be on the supplements for at least 3 weeks before we follow up. That helps to give me a partition or ability to ascertain how helpful diet is compared to whatever supplemental intervention you're administering. And then also, I oftentimes will have them start supplements one at a time. And usually with probiotics, I have them start, and I use different probiotics, and there's different dose ranges for all of these. But I usually have them start at what would be considered a lower dose and give that a couple days and then add in the next one. And I usually start with a lower dose of probiotics, maybe, for example, for a lactobacillus bifidobacterium, about 100 billion per day. And with Saccharomyces boulardii, I believe this would be about 2.5. I believe the typical unit of measure with Saccharomyces boulardii is milligrams. Typically, I believe it's 2.5 to 5 is kind of the range that you see, and I have them start with about 2.5. And if they respond well to that, then we may increase the dose at their next visit. If they've had a negative reaction, you've started at a lower dose so as not to cause a inflated negative reaction. And then we may, in a second phase, for example, have to also treat something like SIBO directly with antimicrobials. And so we'll maintain the same probiotic dose we initially established, go into our second phase if that's treating something like SIBO or H. pylori. And then what I like to do is wait until we're done treating the H. pylori or SIBO or whatever it is, and also until we've achieved someone's peak level of improvement and they've been stable in that peak level of improvement for 2 months. And then I first have them do a dietary reintroduction. And once that's done after about a month or so, and then we have someone slowly wean themselves off of their probiotics. And there's really not a magical algorithm to this or process. I just tell them, take one of your probiotics and slowly wean off of it. And I'll tell people, if you're if you're just wanting to get off these now, just stop one cold turkey, give it a few days, and if you don't notice any problem, stop the next one cold turkey. If people are a little more cautious or they're a little bit more wanting to be on supplements, I'll ask them to slowly wean off. But essentially what you're looking to do is get someone off something and see if they notice a negative regression. If they don't notice any negative regression, then they don't need it anymore, and we have them discontinue. If they do notice a negative regression, I have them go on a small dose, maybe a half or a fourth of what they were doing before, and see if that's enough to get them back to where they were before. Really, it's not very complicated. So that may not sound like incredibly, definitive answers, but really, it's not that precise of a science. Where the overarching concept is get someone to their peak level of improvement, have them discontinue what they're taking, and try to do it in a manner where you isolate so that if someone does regress when stopping a probiotic, you can pinpoint where that regression is coming from. If you do notice a regression, have them go back on and see if they notice that that regression abates. And if it does, then have them continue. And then revisit trying to wean them off again later in a few months. If after a few attempts they can't come off of it, then it's probably something they're going to need in the longer term.
Okay, great. Can you talk just a little bit more maybe about the insoluble fiber and dealing with chronic constipation?
Okay, any specific question there or just in general?
Kind of just a general question.
Okay. Well, I mean, it's really, quite simple. The studies that have been done show a higher incidence of adverse reactions when using insoluble fiber, and that is why the soluble fiber is recommended. Now, this may run counter to what some people would think, because a soluble fiber is more fermentable, and sometimes fermentation can feed these imbalances in the gut, which is why we see such nice benefit with something like a low FODMAP diet. However, that's why I come back to not making mechanistic speculation, but rather looking at what the clinical outcome data shows. In this case, it would potentially seem that in someone with IBS, potentially, or especially someone with SIBO, they would do better on a minimal or non-fermentable fiber as is insoluble fiber. However, that's not what we see in the clinical studies. We see that the least amount of negative reaction occurs with soluble fiber, and it has a nice benefit on laxation. That's the main or the most consistent or the most pronounced benefit we see with fiber in IBS is a positive impact on constipation.
Great. Okay. Thank you. Okay. Do we have any more questions from our participants? It looks like we've got a quiet audience this morning. Thank you, Dr. Ruscio, for being with us today. That was great information. We really appreciate you sharing your clinical research with us. Keep keeping us informed, please.
Absolutely, my pleasure, and thank you again for having me.
Yes, and so you can go to Dr. Ruscio's website and take a closer look. We appreciate his content on that site. And this brings us to the end of our discussion. Thank you, Dr. Ruscio, and everyone for attending. A recording of today's broadcast will be sent out soon. And if you have questions for our guest, please go ahead and forward those to his email that's provided. Next month, September 14th, we will have Mr. Kerry Schurer, who is a live stream expert on social media content and web video communications. So please join us. Mark your calendars for September 14th. Again, here on The Scoop. Thanks for joining us and have a great rest of your day.